heaven.
Hello everyone, this is Data Driven Chat, and today my guest is Krish Nirantharakumar. I know Krish for quite a few years, but I think in the few last years we have lost touch. We kind of worked together at University of Warwick, and then even though we're working together in the same university now, we kind of don't see each other much because he's so busy. He is a senior clinical academic at the Institute of Applied Health Research. He is also UKRI Innovation Clinical Fellow at Health Data Research UK and honorary consultant in public health medicine. Is that correct, Krish?
That's correct. And thank you for having me in your data-driven chat.
Thank you so much for finding the time. I know it's very, very busy time for you. And today we're going to talk about a very exciting topic, which is health informatics. And Krish is an expert in health informatics and generally, I think, digital health. So we are going to kind of go in depth today into this topic. Krish, to kick off our today's discussion, can you tell us what is health informatics for those who do not know what it is, and how did you become interested in it?
Thank you. So everyone defines health informatics differently. To me, health informatics brings together three key disciplines. So this is information science, 2, computer science, and 3, health science. So using information science principle, we collect data, we clean them, we code them, we structure them, and analyze them to provide valuable information for healthcare. Using computational science principles, we are able to collect and store data efficiently, securely transfer and share data, and use computational techniques to develop algorithms and technologies, which we then go and apply in health discipline. So when we say we apply in the health discipline, we apply it to either prevent disease. If we are struggling to prevent disease, we want to detect disease early. So that's another place we use it. And once we detect disease, it's important we treat them and control them well. So that's the third stage we use it. So essentially bringing together three wonderful disciplines together, and that brings to you health informatics.
Wow, that sounds exciting. So can I just ask you to maybe elaborate a little bit on this, and can you give us an example of how this works for maybe one particular condition or disease, so the detection and then, the application, just maybe a brief example?
Oh, yes, definitely. So if you take a condition like diabetes, so I work a lot around diabetes and endocrinology. So the best thing as a public health physician I should be doing is to try and prevent diabetes. There are a number of ways we can do that. So this might be public health measures, which might be communicating about the risk of diabetes, being able to identify people who are at high risk of diabetes and provide them with the right intervention, and many other interventions. So let's take, how do we identify high-risk patients for diabetes? So what we can do is, because we have wonderful electronic medical records in UK, we can use those huge volumes of data to develop algorithms which predicts who are at high risk of diabetes. And these algorithms can be then implemented into electronic medical records to identify these high-risk population, bring them in, and provide the right advice and intervention. So that is about preventing disease. Mm-hmm. The second part is about detecting disease. So in UK, almost 20% of people with diabetes do not know they have diabetes. And that is a major issue because later on they can come to hospital with major complications. So what we can do is also implement health informatics and tools to detect patients. So again, for example, by identifying high-risk people and then testing them, means that we can identify those who have diabetes early on and intervene so we prevent complications. Then we have the treatment arm of it, where we like to provide them the right medications. There are a number of medications in diabetes. And sometimes some medications work for some people and others work for people who have particular characteristics. So we can try to understand this using artificial intelligence, machine learning algorithms, and so that we target the treatment to the right people who will benefit from them, rather than prescribing without that additional intelligence. So I have just given you an example in diabetes, how we can really implement health informatics to improve the benefits to the patients.
Okay, thank you so much. Yeah, and I want to go back to kind of the previous question about how does one get into health informatics? Because a lot of people who listen to this podcast, they are aspiring kind of data scientists, so people who aspire to a career in data-driven industries, so data-driven professions. So can you tell us a little bit, how do you become an expert in health informatics?
Okay, I could tell how I did, and
yes,
then
yes,
also give
yes,
some
please.
Examples of people who can do that from other disciplines as well. So to be a health informatician, it is not mandatory you are from a health professional background, for example, even though I am. And so you could come from a mathematical background, you can come from a computer science background, or you can come from a health science background. So for me, I went to medical school, but I had a gap year. And in that gap year, I was always interested in computer science and data. So I went and did a diploma in computer science before going into medical school. And when I was in medical school, I found medical statistics and epidemiology the most interesting subjects, not the cardiology, not the neurology, but medical statistics and epidemiology. Epidemiology is essentially, you're like Sherlock Holmes. You are investigating what causes disease, how disease behaves, and how best to treat them. And that excites anyone. So having this knowledge of computer science, interest in statistics, and being trained in the medical sciences, obviously led me to a career as a health informatician. So as a health informatician and a clinician and a public health physician, I'm able to focus on an individual patient need. So when a patient comes to a doctor, how best to use information and technology to improve care, but also at a population level, how do we improve the health of a population? But if you come from a different background, let's say you come from a computer science background, I always say there are one key area you can work on. There is so much opportunities and so much need, and more importantly, where you actually give the benefit back to the population is health informatics. And there is a huge need for mathematicians and computer scientists and behavioral scientists as well. How do we use this technology to influence? Technology is there, but how do we influence the behavior to ensure the best possible health for the population? So if you're coming from computer science, it's very important that you work very closely with the health professionals, because there are so much in the data that can mean different things to different people. And understanding the data, the structure, the limitations, and the strengths is a key part of becoming a health informatician.
So yeah, I mean, this is all very exciting, especially, I mean, I think we will come back to your expertise in epidemiology, because this is probably the most wanted skill right now, right, in the current conditions. So if we just for people who do not know your work, I will obviously make references to your Google Scholar page in the podcast. But for those who do not know what you do, can you give us an example of one recent project that you have done, and basically tell us what lessons you learned from this from this project, just to give people a taster of what you do?
Okay. So there are a number of things I work on. I work on large databases, particularly primary care databases. So these are databases that come from general practice to answer important clinical question and public health question. That's one aspect of it. Mm-hmm. The other aspect of it is about developing methods, and that's the example I'm going to give you now. So recently, in the last 5 years, our focus has been building a platform to perform what we call automated clinical epidemiology studies. Okay. So what is this automated clinical epidemiology studies? So if I want to answer a question using a large database, healthcare database, the database has huge problems. So, for example, the database I work with has almost 20 million patients.
Wow, that's
10
a lot.
billion data points. And for us to delve into it and develop a study design that is not biased is very, very difficult and time-consuming. So if I were to go to someone and ask, I need this data, I need it according to this study-specific design, it could take easily many weeks for me to get that data. Partly because it takes time to write those codes, partly because one person will have many projects to handle. So it's quite frustrating when you think you had to wait for months to answer a question. So what we did was we developed a platform. Working with computer science, my colleague, a very clever computer scientist, Krishna Gokhale, and team developed a set of software tools, which we call Dexter, acronym standing for Data Extraction for Epidemiological Research. Now that we have this software, what used to take us easily 3 months is done in 3 hours. Mm-hmm. It's a huge transformation. And we were probably the first to innovate this in UK, and there are some examples in Harvard, for example. And this meant in the last 3 years, we were able to publish over 40 peer-reviewed publications, including a number of papers in so-called high-impact journals. We were able to create a system where the research is reproducible and transparent, mm-hmm. and has attracted millions of funds to the college and the university, enabled a number of doctoral students and many MSc students.
So just to kind of clarify, so the platform is used by health professionals. Basically, is that in the public domain, or is it accessible to a group of academics? Who uses the platform? Can you just tell us?
Well, the platform sits on top of a data. Mm-hmm. So the database obviously is not something we can share because obviously it's got patient data.
Of course.
It's anonymized, completely anonymized, but we cannot share because the data providers will not allow that. Mm-hmm. So the platform at the moment is based at the University of Birmingham.
Okay. Mm-hmm.
And researchers within the medical school have to register, get permission, and then start using, because there are potential adverse impacts as well. If people start accessing data they don't have the right to. On the other hand, for organizations that are interested in implementing the software for their specific primary care database, we help them do that. For example, we helped a university in Maastricht in Netherlands to do so. The tool is also being now trialed in Public Health England for providing surveillance. So there are a number of avenues to access the tool. At the moment, the best way is to get in touch with us. Obviously, it involves a number of stages before we can implement it. So, for example, depending on the type of database you have, it might need to be modified to bring to a common model, and so on. Okay.
Yeah, you probably also need ethics approvals, because I remember when I did clinical projects, you needed like a number of ethics approvals from various committees to be able to work with, human subject data. Is that also the case? I guess it should be the case.
Well, not for the software, but yes, the underlying database you need to get approval. But the good thing is, because it's anonymized data, it has ethical approval to be used for research. However, you need to get what we call a scientific review committee approval. And unfortunately, the license for the data we hold only is available at University of Birmingham, whereas other universities will have their own license for the database. This is not something to do with us or the university, it's the data provider who charges a fee for us to use the data and have restricted number of users.
So you do all this exciting work, but if I had to ask you to pick one thing that you're particularly proud of in your career, what would that be? I know it's a difficult question because you do so many things, but if you had to pick one.
Easy question.
Oh, okay, awesome.
So obviously we do plenty of research around clinical area. We do methodological work like what I described, but those methodological work are only possible by working as a team with computer science, health data scientists, clinicians sitting together. But if you ask me to pick one thing I will be proud of today and probably forever, it is about getting the next generation of clinical and public health informaticians and creating those cohort of junior academics who later on go and do amazing things I could never have imagined I would be able to do. So I strongly believe in supporting those junior colleagues and doctors and academics who are very passionate about becoming health informatician. So I was fortunate to lead a master's program in public health and a module on health informatics. And we did a lot of things to improve the program, but also engage the students in health informatics. And many of them later went on to do PhDs. And also mentioning the tool we have created, all of a sudden, clinicians who never were able to understand this database, never were able to access this database, are able to now actually work on those databases if they are NHS colleagues. And even medical students. There is one medical student who always comes and works with us in a summer, and she has already got 5 publications she has contributed to. So enabling the juniors, particularly junior colleagues, and making them the next generation of health informatician, I think is the best way you can invest your time.
Yeah, this is really exciting, and I like how you you mentioned something that is maybe not only the kind of the personal thing, but kind of going out to the entire community of people who want to do research in health informatics. So obviously we cannot avoid the topic of coronavirus. I'm sorry, you're probably sick of this topic because probably everybody asks. But I mean, since I got you and I got your time now, I will ask you a few questions about that, if that's okay. So, so obviously, when the coronavirus hit, the globe. which important questions do you think were highlighted in health informatics and generally in health research? So potentially questions that you have already worked on, but maybe there were some new questions, so maybe some new issues that this crisis kind of brought about.
I would say that there are questions related to data science, and then there are questions, I would say, related to more technologies.
Right.
So if you take data science, the moment we come across a disease like this, we need to rapidly understand the evolving epidemiology. So, for example, who are the people who are being affected most? And what is the mortality rates? What is the hospitalization rate? What is the intensive care admission rate? What is the number of people who need ventilators? So if you have really good information systems, you can answer those questions. And you can see that particularly in UK, because we are blessed with so much good information systems and data science tools. You would have seen a number of publications coming across the country using 17 million patient records, and on one occasion, the whole 60 million patient records. And that has enabled good insight into those who are affected, for example, by coronavirus. Now, that helps us to shield them, that helps us to ensure they take the right precautions, and so by doing so to prevent any harm occurring to them. Then there has been questions about medications, what medications are safe. Now, this is an area we are working on because routinely patients, particularly diabetes patients with high blood pressure, patients with arthritis, take a number of medications. And some of them have been questioned, are they harmful? Or are they actually beneficial?
And also, as far as I understand, I don't know, like maybe you will tell us, but the people who have, for example, heart conditions, high blood pressure conditions, they're also in high risk, right? Diabetes patients also in high risk of COVID.
That's correct. So what we have observed so far, there are two things we need to look at. One, who are the people who are at high risk of death? And definitely those who have previous comorbidities, as we call it, health conditions, such as diabetes, high blood pressure, cardiovascular disease, who are receiving treatment for cancer, those who have a condition that suppresses their immune system. Those are patients at high risk, and importantly, also elderly patients are at high risk.
Right.
So this was all possible to understand because we have good health systems that collect good data. But we also know some medications may be beneficial, some may be harmful. For example, you probably heard enough of hydroxychloroquine.
Right.
So at one point they were saying it was beneficial, and now recently a clinical trial concluded that it was not beneficial. But there are questions about other medications where you might not do a clinical trial because you believe it is harmful. So for those sort of questions, you have to get your answer using large databases. There is no other way of getting information. So that's something we could work on. But also don't forget about all the modeling studies that happen. What happens if you put lockdown measures? How will the infection behave? Or how do you model the epidemic curves? You would have seen enough of those epidemic curves and the flattening of the curves and so on. And then we have the issue of systems and technologies. So how can we have a rapid learning health system where we collect data in a structured way that can be utilized rapidly for decision support, that can be rapidly used for public health measures that can be rapidly used for clinical trials, that can be used for clinical decision-making and research. So those things are important. And lately, of course, the technology like apps for testing and tracing. So, as you are aware, NHS is trying to, with Public Health England, develop and implement an app. We are still waiting, but I'm sure it will happen very soon. But those sort of technologies also come into play, how best to ensure we got a good app, but more importantly, it comes down to your expertise on how do we ensure people then make use of those apps, the behavioral data science side of things, and efficiently, accurately enter those information so we as a nation can recover from this terrible illness.
Yeah, exactly. So yeah, I mean, I kind of voiced kind of the initial concerns about, how the behavioral science is going to be done. So I'm really glad that now, NHS is thinking about this. So because initially I think what I saw was very, very worrisome in terms of behavioral design. I know that you probably cannot tell us everything, but so currently your work on COVID, can you tell us what you're working on now in some kind of high level way?
Okay. In COVID-19, yes, there are a number of things we are doing. One, of course, support our local services. Mm-hmm. And secondly, do some research as well.
Right.
So in terms of supporting our local services, locally, we have a fantastic hospital, University Hospital Birmingham, which has its own electronic medical record, which was built in-house. Called PICS, Patient Information and Communication System. So they have been very responsive to what has happened by actually using that data they collect in the electronic medical record to understand what the disease does and who are the people who are getting affected by COVID-19. So we have been helping them with that. And we were probably the first to report within a hospital setting led by Liz Sapey with our support and Professor Simon Ball about the ethnicity impact in hospitalized patients. So people talked about in a population how ethnic minorities are affected, but that could be due to high infection rates rather than the infection being severe. Right. Okay, so if you live in a crowded house or you are socially deprived, you're more likely to get infection.
Yeah, extended families that we have in some communities, right? Yeah.
Yes, exactly. So, but what we were able to show that it was beyond that. It was beyond that, and that not only they get infected, but they also get severe infection. But also then are at high risk of death. But this was mainly on South Asians because Birmingham has a huge South Asian population. And that is in preprint, so it's available publicly.
Yeah, I'm going to make, I'm going to link this podcast to the paper as well. So yeah, thank you for sharing this. This is extraordinary. I didn't know about this at all.
Right. And there are other things we are doing. For example, we were supporting the hospital to map where the hotspots are. So the hospital, working with the public health department, were able to alert these locations and ensure public health measures were in place to reduce the spread of disease. Similarly, we helped our local authority with modeling what to expect, how many patients to expect, and so on. And we are also working with Professor John Fox from Oxford University, who has an open clinical net platform where we are modeling data collection forms and how that can help decision support and learning health systems. As I mentioned earlier, we are looking at medications, if they are safe to prescribe during the pandemic or not, because the public need that reassurance about the medications they take, because there's a high chance more people may die because of pre-existing conditions where they don't take their medications or they don't access healthcare as much as people dying from COVID-19. So it's important we don't forget those aspects and ensure the health conditions are well managed, pre-existing health conditions. We are also looking at the impact of COVID-19 in specific groups of patients and why this may be and how we can address this. And my colleague and Professor Shakila Thangaratnam is working across with World Health Organization, producing what we call living systematic reviews. So some of our junior colleagues are working with her to help with those. So there's a number of things ongoing, all in our small contribution towards the research community. And hoping that together, because it is an issue that has to be handled collectively as a nation. There's no heroes here. It is everyone have to do their bit, and we are trying our best to do that and contribute towards tackling the COVID-19.
Yeah, all this sounds fascinating, and I think I will be speaking for the audience of this podcast and beyond. Thanking you for your work and for saving lives. That's very important. So thank you so much for that. One thing that I noticed, and that's something that kind of comes up in a lot of conversations, is the availability of testing, right? The availability of tests. I personally, we had a case in my household when my son exhibited what we thought could be the symptoms back in February, and we couldn't get access to testing because I think the screening that we had at the time, at least, was that if you were not in close proximity to a confirmed case of coronavirus, you couldn't get tested. But we still have this problem, right? So in your view, first of all, is testing the right way to do we need testing like this, mass testing? And second, when do you think this problem would be solved? I mean, will we get to a point where, everybody gets, test in the mail or something, and, you could easily do that?
Yeah. So testing is a very interesting and a bit of a controversial subject, but so there are two phases. What our response here in UK was early in the pandemic and what happens now. So early in the pandemic, we were testing what we called a PCR test, polymerase chain reaction test, PCR test,
right,
where you take a swab from your throat or your nostrils. And initially, when there were few patients, they continued doing that. And that's important because if you test only, you will know someone has an infection. And if someone has an infection, then you can quarantine and also shield people from them. So we don't end up affecting the vulnerable population. Unfortunately, and I say this very unfortunately, I don't think we were prepared well enough. And we discontinued testing. And I think that was a terrible mistake, but something they couldn't avoid because one, they didn't have sufficient kits. And secondly, they didn't have sufficient personnel and the logistics to operationalize this. And that's something hope they have learned from their mistakes. So it's pointless saying we haven't made a mistake. We have made a mistake, and I think we should have prepared better. Now, that has meant a lot of people who had the disease, like you said in your household, and I myself had it, and I couldn't get tested.
Oh, God, okay.
Even when I tried privately to get a swab sent to us, it took another 3 weeks by the time I had got better. So it was frustrating. There is no question about it. the good news is now you can get tested, but you can get the swab test done if you have symptoms of having coronavirus, which is simply high fever, cough, or issues with your smell and so on. Now, but there is a different problem now. One is how long it takes for the results to come back. Mm-hmm. So there have been issues how long it takes, and that has been worrying. Then there is another type of test, which is your antibody test, where you take a sample of your blood and you look for, have you had past infection? It can also detect current infection. We call it the IgM antibody, and then it can test for past infection, which we call the IgG antibody. Okay. Now, these tests are approved now by Public Health England, but only accessible to people like health professionals who mm-hmm. work in hospital setting. So I personally would like to get myself tested to check if I did have the infection or not, but right. That's not directly available for me at the moment. And that can also help, because knowing if you had the infection can be helpful. But what we have to be careful about that. We still don't know a lot about the COVID-19 infection. For example, we don't know if we get the infection, if we are protected from the infection in the future. We may be, if we do, probably we are, but mm-hmm. if we are, we don't know how long we are protected. So does my antibody and the memory of those infection last only a year or two? How does this virus mutate? And if it mutates, do we still have protection? So these questions are still to be answered. So even if someone has had the infection, they should follow what the government says, should maintain social distancing, and should do exactly what they have been asked to do. So in summary, I would say we are in a better situation now than how we were in till April. We can get tested, so I would encourage anyone who exhibits any symptom to go and test it. But also be aware that only 70% of those who have the disease are likely to be tested positive when you have this swab test. So if you get a negative result, but you still have symptoms, then definitely discuss with your general practitioner, self-isolate yourself for at least a week, and ensure your family are isolated at least for 2 weeks.
Awesome. So thank you. Yeah, thank you, Krish. I mean, I think this is very important. And yeah, thank you for providing all this depth on the tests. Because if, for example, I didn't know about the posterior test that existed. So that's, I think, will be news to many people. You kind of touched on this already, but I still want to ask you this. So there seems to be a lot of work in data science right now on COVID, where people basically run with data sets that are not the type of data set that you have. And also people do not work with clinical practitioners and people like yourself, clinical academics who know a lot about, patient data. So in your view, so data science currently, is it kind of inhibiting the health informatics, or is it helping? And equally health research. Does data science help the health research, or does it inhibit it in the current conditions?
Well, I'm going to say predominantly scientists have extensive, has been very, very positive. Mm-hmm. The number of examples in the hospital, how data scientists worked with clinicians to ensure this reporting of high standard, the analysis is of high standard, and the quality of their data, depending on the quality, the correct questions are asked. Mm-hmm. And the secret behind that is working as a team science. It's simple as that. So a data scientist without the knowledge of health science or public health or clinical medicine cannot attempt to do research with healthcare data. And the same goes for clinicians and public health physicians. If you don't work with the right data scientist, the right statistician, the right computer scientist, you're always going to get it wrong. And to be honest, the clinician, simply because the methodologies might be not appropriate, despite the question being a very important one. So it is important. Computer scientists, data scientists, statisticians, epidemiologists, clinicians, public health physicians work as a team. You even take one out of it, then you are going to end up with some spurious results. So important to collaborate, important to work as a team, particularly in a situation like this where collectively we all have a responsibility to improve the health of the population.
Mm-hmm. And just kind of zooming out onto the future of health informatics. I know that it's very hard to predict, especially considering what is happening with coronavirus and everything, and how everything is changing in the matter of weeks. But what do you think would be the future of health informatics in the next 5 years? What would be the hot topics, key questions?
Coronavirus obviously has been detrimental to health, science, and everything you can think of. But there is also a positive side. So I told you how people use 17 million patient records, how people use 60 million patient records. If we wanted to do that in a situation where there was no coronavirus, it would have taken another 5 years to do that. Just going to get the permissions to all the governance issues and the red tapes, we would have never, ever be able to do things like that previously. And all of a sudden, within a week, within weeks, people were able to do such research at scale. So I believe in 5 years' time, now that people have realized, one, the potential of the data, two, the barriers to get this access to this data, there will be more thinking around how do we make this data available, at the same time protecting the privacy of the participants who provide that data. And how do we make it accessible to every researcher as opposed to a selective few? And how do we do that? And how do we ensure we nationally work in the spirit of team science, which is what Health Data Research UK stands for? So how do we ensure people work together as a team and make things work? So that's the first thing I would say I would expect in 5 years, data made available efficiently in a form with tools like the one I described we produced in Birmingham to enable everyone to do research. The second thing I think is about learning health system. So if we have data that is real time, there are a number of things we can do. One, we can implement decision support systems, which can help individual patients, which also can help with decision making at a population level. If we have really good clinical system, we will see what we call data-driven clinical trials. So this is where you don't have to go and recruit patients the usual way by sending letters and whatnot, but rather through the electronic medical record, patient consent is obtained, they are randomized and new therapies tried out, and the outcomes are measured from electronic medical records rather than the patients having to come back. So that's going to happen. The other thing you will also see is more and more we recognize, even though the gold standard is clinical trial, most of the decisions made in healthcare, almost 85% of the decisions made, are not based on clinical trials. It's just not possible to do clinical trials to every single question. So in such circumstances, can we emulate clinical trials? How do we do that well, as much as we can, to inform decisions, particularly in certain characteristics of population where we never do trials? For example, the more elderly patients or those with multiple conditions. We rarely do a lot of trials. So it's in those people we can learn from emulating clinical trials. And then we have the artificial intelligence to support us to analyze those data, and then, as I mentioned previously, precisely be able to identify who will benefit from a particular therapy and being able to target those people with those particular medications.
Mm-hmm. So you already told us a lot of examples of your current work, but I mean, I still wanted to ask you, what makes you currently excited about your, or do you probably do not have time to get excited? You're probably so busy with everything. But yeah, what keeps you awake at night? What makes you particularly excited about the current projects that you do?
One of the things, I would say one of the things we wanted to do was on building on the platform we got for automated clinical epidemiology studies, the Dexter software, is to do a particular project called ASS 24. ASS means automated clinical epidemiology studies. 24 means within 24 hours. Can we answer a question using data within 24 hours and either have a manuscript ready or produce the analytics and the results ready? And we know we can do it with the tool we have. But there are challenges, and that keeps me awake because one, how do we get the approval within a short 2 to 3 hours? Just imagine a clinician comes to me and says, this is the question. Then immediately I need to first check feasibility and then to write a protocol and then get it approved before I can press the button to get the data and the analysis done. So that's quite exciting and that keeps me awake. And I'm also not sure what the reaction will be from the research community. There are a lot of people who are positive about these things, and there are others who are critical. Just like when automated cars come.
Yeah, it's like Dr. House, what you were explaining. So it's like, yeah, basically, yeah, you can get probably very, very quick understanding of what's going on, right? And that's, I can see why some people might be skeptical. Yeah, my mom is a medical doctor, so she's very much kind of, you need like a human touch to everything. so I can see why some people would be cautious. But I guess it goes back to your point about the quality of data, right? If you have the right data, you should be able to do it very precisely and very quickly and very efficiently, and people shouldn't be concerned, right?
Yeah, there are two aspects. So the one I'm talking about is automated clinical epidemiology studies, which is research. Then, of course, there are the automated decision support tools, which is actually clinical practice. So we need to make sure that these are two different things. So the one I'm focusing is on research.
Right.
And we will always need researchers. We will always need epidemiologists. We will always need data scientists. There's no question about it. How they adapt and learn and change their role will happen. Now, some said if you create systems like this, people may lose jobs, for example. In our case, our team, which was just 2 of us, has become 20. And that is simply because of the tool. We are able to do more research, attract more funding, which means more jobs. not less jobs. So we have to be clear that it actually creates opportunity rather than taking away opportunities. As opposed to clinical decision support system, another area I'm interested in, you can never lose the touch of a human being when you have a health professional. You take that away, then there is going to be always adverse effects. There is no question about it. So decision support tools are there to help you work efficiently, improve the quality, ensure we provide the right treatment, rather than to replace anyone. Because we always need doctors, we always need nurses, and that's never going to change. But what we can do is give better care, better quality care with these sort of tools. So there's no reason to be skeptical. It will happen, but it takes time. And down the road, there will be errors, mistakes from which we need to learn. Wherever possible, we need to test them sufficiently so there are no mistakes and it doesn't cost a life or something like that.
Yeah, I think you're absolutely right. I mean, this is the progress, this is the future, and we should embrace, these tools and with, obviously responsible testing and right data, they can do a lot of good, right? So yeah, this is kind of the last question I always ask. And everybody complains about it, but I will ask it again. And so the question goes like this. If I ask you to recommend just one book and one film, what would your recommendations be?
I read a lot of biographies. And the one that stands out right now is one on Ben Stokes. I don't know if you know him. He's a cricketer. It's called On Fire, My Story of England's Summer to Remember. I'm a great fan of the game cricket, and cricket comes in many forms. You get the shorter form, what we call one-day cricket match. This is similar to our work program ASS 24, where the excitement is everything happens within 24 hours, just like we want to do research within 24 hours and get an answer. And then there is something called test cricket. This is takes time. It takes 5 days to play the game. And this is similar to data-driven clinical trials, where you take a long time to do clinical trials. But actually, there is no room for error in such sort of cricket. And it takes time. You need patience. But the final reward is much more satisfying than the one-day cricket, the one that is exciting, flamboyant, and you see lots of shots play. So in this particular book, Ben Stokes actually excels in both one-day cricket when we won the World Cup, thanks to his amazing skills. And then we were also fortunate to witness one of the best test cricket, where he won that important match against Australia. So very inspiring. And it tells us it takes a lot of hard work and passion to get there. So I would say that's the book to read if you're a cricket lover, or if you believe in hard work and passion to get to your goal.
Awesome. Thank you. How about a film?
There's one movie I have probably watched many times, the Pursuit of Happiness by Will Smith. And then it reminds us that happiness is very relative, and that we should be driven by what we wish to do, not by what others want us to do, and that it may bring hardships, but at the end of it, you have the passion, and if you have given your best, then you're going to find light at the end of the tunnel. And that sort of inspires me to keep going and go for what you believe in, and make sure it works.
Well, I certainly hope that you will keep going and, continue your fantastic research. And thank you so much for finding the time and talking to me today. I certainly learned a lot. I mean, this was not just a chat. It was really inspiring and, enlightening in many ways, because, I didn't know a lot of things that you were talking about. So thank you so much, Krish, for this.
Thank you. Thank you for this amazing opportunity. And I hope we have together inspired the next generation of health informaticians. Thank you.
Thank you so much.